day 2, Eyes on Dry Eye 2025. I'm Dr. Damon Dierker, your co-host, and I've been here all weekend on the exhibit hall stream. So this is day 2 of the hot seat. This session is sponsored by Bausch & Lomb. This is a 30-minute session where Eyes on team has solicited some questions prior to the event. I'm taking questions in the chat now, where basically you can ask me anything about dry eye disease and I'll give you my answer. And full disclosure, a lot of the folks in the ocular surface disease space I do consult with. I will let you know when I think something is definitely my opinion versus something that I believe is evidence-based. And I'm only going to be speaking about things that I have direct personal knowledge on. If I don't, I'll say that and then give you the best answer that I can. So I will be monitoring the chat over here on this side, and then eyes on if you want to fire away and let the questions go. So round 2, I survived round 1. This is no longer Friday Night Lights. It's Saturday afternoon, maybe a little bit more relaxed, but we'll see what happens. All right. First up, Lauren. Lauren says, manual expression after RF or low-level light. Is that effective? Yes, it can get a percentage of meibum out, but won't the gland still truncate without full expression like lipoflow? So, great question. Looking at patients that have obstruction of their meibomian glands as part of their ocular surface disease, and we know that that is going to be a large majority of our patients. Patients with evaporative dry eye typically have MGD and typically have some level of obstruction. Not everybody has obstruction. Maybe somebody that's more ocular rosacea can have still what looks like, oil that comes out of their glands, but instead of being like olive oil, it's more like kerosene, it's a pro-inflammatory. But expression after RF or low-level light, is it effective? I would say yes, in my experience. I don't have personal experience other than a couple of workshops doing expression after radiofrequency. I have extensive experience doing expression after low-level light, specifically with a red wavelength, doing expression after tear care, which is adhesive heat for 15 minutes, followed by manual expression. And then to the second part of this question, I actually do express after my lipoflows. So lipoflow is automated thermal pulsation, heat on the posterior lid margin, and then automated expression. But there was a study that came out in 2021, I believe out of Asia, that looked at lipoflow alone versus lipoflow plus manual expression. And they both worked at improving meibomian gland secretions and removing that obstruction, but it seemed like the effects were better in patients that had lipoflow plus manual expression afterwards compared to just lipoflow alone. So when I do my lipoflows now, I do manual expression after the vast majority of patients. I am commonly doing low-level light in patients that are mild to moderate inflammatory plus obstructive dry eye, where I will do 3 sessions of red mask spaced out by about a week. I will generally express after every session so I can understand the level of obstruction. And as I do treatments, typically the secretion quality is going to improve. Tear care as a standalone procedure, head-to-head versus Restasis, looking at patients that had dry eye, I was actually at least as effective as Restasis at improving symptoms, and then certainly improved more than Restasis on tear breakup time and meibomian gland function. So I think that it is effective. I think it is necessary. I think where there are some folks that say, hey, I got IPL, I'm doing treatment, but it doesn't seem to be giving me the sort of results that I'm looking for. Well, let's make sure that you're addressing the obstruction, whether that's after an RF or a low-level light, or doing a FDA-cleared procedure like a lipoflow, iLux squared, or tear care. So I don't think that you necessarily have to get all of the meibum out every time, but you have to get that meibum moving, and doing that with expression either in an automated manner, automated plus manual, or manual alone after some sort of heat source is going to be helpful for your patients. Hello, Cassandra. Thank you. How does my meibomian gland probing not permanently damage the delicate gland tissue? So I'll read that again. How does meibomian gland probing not permanently damage the delicate gland tissue? So a little bit of a loaded question. I definitely have some colleagues that are advocates of probing. One of those would be in a limited manner, at least, would be Ahmad Fahmy. So if you want his impression on that, you can send a direct message to him in the chat, in the peer-to-peer. I think that there is definitely concerns that if you not done properly, that you could damage the very delicate meibomian glands with probing. I've seen reports of patients that looked like they had some iatrogenic damage to their glands after a probing that was done. And it's a difficult procedure. I do have patients that occasionally go elsewhere for that. I do not offer probing myself. I think there is some value there if done properly. It doesn't last forever. And I am concerned that could I do something that could make this patient worse long-term? We just don't have a real great data set on long-term patient success after having probing as part of their meibomian gland treatment. So I am cautious about recommending that. I do not do that myself. And I do think that it is possible to damage the delicate meibomian glands with probing. I'm looking at the chat. Cassandra, thanks for contributing. I'm finding while treating chalazion with low-level light blue-red, patients have been getting more hordeola during the course of treatment. I'm in Canada and don't have access to XDEMVY. Thoughts? So I think, great question. And I do use both low-level light and IPL, sometimes alone, sometimes in conjunction. I continue to play with that a little bit in terms of my algorithm. Is I think that appropriately, you did note that this patient may have DB as part of the process here. So I think removing the biofilm, treating with XDEMVY, if that's available, not available in Canada, I think that may be part of the problem. You know, somebody has an acute situation and it's swollen. I'm not going to really do a whole lot of expression for those patients, but I can't really say that I have a similar experience where I am seeing the patients having an increased frequency of chalazion hordeola after I do IPL low-level light. I think that it is possible, and I can think of one or two situations in the last few years where I may have seen somebody have one during that procedure, but it is something that is not common in my clinical experience. Great. Appreciate the questions. Keep firing away. I am going to address one that has come up at almost every session, and it came up yesterday in the first hot seat is, can you give any advice on getting prescription dry eye medications at a lower cost to the patient? So I think that we have to have a good understanding of the rules of engagement here. Not every medication that we want to prescribe for a patient is going to be available for every patient. That's just reality. But where we fall short is if we're not taking advantage of the programs that are in place to help our patients, whether those patients have commercial insurance, Medicare, Medicaid, or in some cases, no insurance at all. So to do that, I lean on the pharmaceutical companies that are putting these medications out to market to help me with that. And what I do is try to utilize as many of their resources as possible. One of those things would be using a specialty pharmacy. And we say, Damon, hey, my patients have been going down the road to the local pharmacy their whole life. They don't want to use a specialty pharmacy. My verbiage that I have adopted, and I'm going to give Kayla Campbell, who's in West Virginia, one of my former students, she's doing a great job doing an OSD as well as primary care. The verbiage that you want to use is, I'm prescribing a specialty medication for you, and that requires going through a specialty pharmacy. End of discussion. There's no, can I set it here? This is a specialty medication. We're going to use a specialty pharmacy if that is part of what is going to give patients the best access to that medication. There are manufacturer coupons that you can give to a patient that has commercial insurance in the United States that they can take to local pharmacy. I don't want to deal with that. My staff doesn't want to deal with that. I want to limit the number of callbacks, limit the number of questions that we get if they go to a retail pharmacy and get information that is not correct, or they go to a retail pharmacy and they want to switch them to a generic if one is available. A lot of things obviously are not in the dry eye space. but I want to have a process to do that consistently across my whole practice. We have made it a very strong and protocol in place now to be able to say this patient has this type of insurance, whether it's Medicare, Medicaid, self-pay, or commercial insurance. We want to do this medication. Here's where they're going to go for that. And we utilize our local reps to help create that algorithm. And if you do not have a relationship with a local rep for the medication that you want to prescribe, I would strongly encourage you to do that. By utilizing these specialty pharmacies for patients that don't have a medication that's covered or is covered with a high copayment, these are things then the specialty pharmacies can help direct patients to assistance programs. There are some situations where the patient has to initiate that. So in some situations, I'll tell the patient, if this is something that they gave you a really high price quote at the specialty pharmacy, ask if you're eligible for any savings programs. And doing that through the specialty pharmacy, it's not going to be able to be done at a local retail pharmacy. And then there's certain situations where we have medications where it's really good coverage for commercial insurance, like we have for MIBO. There was a question earlier about MIBO and not getting coverage. Well, commercial insurance, straightforward. I use a specialty pharmacy called BlinkRx for that medication. But then for the Medicare patients, there's good coverage, is not perfect coverage. That's where I'll utilize the sample and say, Mrs. Smith, I've got a sample of this new medication called MIBO. It's the latest technology. It helps to treat evaporative dry eye and acts as a tear stabilizer. This will last you for the next couple of weeks. I'm going to send in a prescription to a specialty pharmacy. If you love this medication and it works as well as I think it's going to, and they give you a fair price, go ahead and get that filled. If you get a price that's really high because it's not covered based on your insurance, well, we'll try again next time. So I try to make sure that I set the right expectation for the patient when I'm trying to be able to get them a medication. Let's look at, what are your thoughts on ivermectin 1% ointment? I don't have any personal experience with ivermectin ointment in the management of Demodex. A phone a friend, Ahmad Fahmy, has. So if you want to send him a direct message, I don't have the ability to get him on this chat now. I have found, at least in the U.S., I can get patients on Xdemvy, and then I will use other things with in-office microblepharoxifoliation, exfoliation, occasionally with other therapies that I would do in the office to help with that, as well as doing lid hygiene or kind of traditional things. But I really feel like the vast majority of those patients that have symptomatic DB, I'm going to use Xdemvy for those patients. Great questions. I very much appreciate it. Nothing too controversial yet. We'll see what happens here the back half of this. All right, question from Izon. How does Blink NutriTears compare to fish oil, 2,000 milligrams, as far as efficacy? Don't know who submitted that question. Blink NutriTears been out for about a year. It's a one a day. That is going to be to help support patients that have dry eye symptoms. It has lutein, zeaxanthin in it. It has curcumin, which is anti-inflammatory, and it has vitamin D. And if you look at the studies on that, one a day Blink NutriTears versus a placebo, it was surprisingly good, where patients were having improvements in their MMP9 levels, their level of inflammation, their tear production via Schirmer's, their OSDI as early as a month. And that persisted out to 2 months in that study. I don't use omega-3s alone typically in my practice. If I am thinking about something other than Blink NutriTears as nutritional support, I will use Hydro-Eye, which is a combination of small amounts of omega-3 and then the anti-inflammatory omega-6 GLA. We do not have any direct head-to-head comparisons of using omega-3s alone versus Blink NutriTears. So to answer your question, we don't have an answer for that. That is something that probably we'll never have an answer for. I'm not sure who's going to support that study to look at Blink NutriTears versus omega-3s alone. I think that nutritional support is important for dry eye disease, and I think that Blink NutriTears is a good choice there. monitoring the chat. Stephanie, appreciate that. We only use specialty pharmacies for anything dry eye. Local pharmacies are no help whatsoever. They can be helpful when you need something today. That's usually not going to be a dry eye medication, and it's usually going to be a generic for most situations. Same thing for glaucoma medications, is that we're in the world, if we want to get patients the drug that we think that they need to be on and make this as good of a patient experience as possible, utilize these specialty pharmacies, save your staff some time. It doesn't eliminate the need to do prior authorizations, but it just reduces the callbacks and makes your life easier. So I would encourage you to do that. Thank you, Stephanie, for that comment. Next question. What is the relationship of dry eye disease, or it says this chronic disease, to metabolic syndrome? Okay. Can improvements in systemic metabolic function help return the tear film to homeostasis? So metabolic syndrome, thinking about diabetes and obesity, clearly those are risk factors for dry eye disease. Those conditions are going to be associated with inflammation, oxidative stress. If you are treating someone's systemic condition that is causing inflammation, which will often show up on the ocular surface, I think it makes sense that you're going to see improvement in their tear film stability. So I believe that treating metabolic syndrome systemically is probably going to be helpful for patients that have dry eye disease. Radio frequency question. I've got a certain device. I've heard some ODs are just doing RF treatments directly over the lid margins without using protective shells. Another speaker said bipolar was okay, but not monopolar. What do you think and why? Boy, it's just not a lot of data on this and no personal experience. I think that if you're doing heat for extended periods of time, and if the device that you are using says you shouldn't be using heat inside the orbital rim, I think you got to be careful. I think there are things that you can do to help protect the cornea at the time of doing a heat or light treatment that is near the lid, but I don't have personal experience in that, bipolar versus monopolar. For monopolar devices, is there any evidence of optic nerve damage from these treatments? I believe I've seen something on monopolar RF in a patient being treated for something that wasn't dry eye that has some sort of optic nerve damage. I've not had any personal story told to me, nor have I seen something in the literature about somebody having a monopolar RF treatment and developing an optic neuropathy. All right, so good question there. Carolyn says, what's your go-to gel drop for patients who are allergic to hyaluronate and all preservatives? So gel drop that is preservative-free, I would probably say Ivisia gel. Comes preservative-free in vials. I believe the lubricant is povidone, and that is something that we actually carry in our practice that I'll use for patients that like the gel or for overnight protection. And then we utilize Dry Eye Rescue to be able to send these things to patients if they want to go online to get that. Checking to see if there's any other questions at this point. Again, thank you to Cassandra, Shala, and Stephanie for your questions and comments. We will move forward here. Catherine Odlin says, are there any oral medications for Sjogren's syndrome? Sjogren's, there's no definitive medication for treating the systemic disease. Patients will be sometimes on anti-inflammatories. They'll be on biologics, immunosuppressive agents. There isn't any oral medication specifically approved for dry eye that is going to be used for Sjogren's, but a medication like pilocarpine or Evozac to help with dry mouth can have some benefits for dry eye. With all of the different tools that we have to help with tear production that don't involve having to prescribe an oral medication, I am not using this, but I do see some patients that get started by their rheumatologist or their primary care physician to treat their dry mouth, have had some clinically significant benefit from pilocarpine and Evozac in Sjogren's syndrome. James Henslick says, give me a summary on MIEBO. So MIEBO has been a topic. It's been out in the U.S. for about 18 months. Approved in the U.S. for signs and symptoms of dry eye disease at QID dosing. And that was looking at patients' total corneal staining and then ocular discomfort on a visual analog scale. And it showed that patients can have symptom improvement as well as sign improvement even within 2 weeks. There's some newer data that was published about 2 weeks ago that showed even within the first couple days somebody is on MIBO, they can start to get symptomatic relief. So I think that's important. This is going to be in patients that have a evaporative component to their dry eye, which is the majority of our patients. In the clinical studies to get the FDA approval, they looked at patients that had established dry eye, reduced tear breakup time, and had some amount of MGD. That was who was in the study. And in that population group, signs and symptoms improved as early as 2 weeks and maintained throughout the study. So I think that QID dosing is what we need to stay on if we want to have that label from the FDA. In the real world, I would tell my patients they can use it up to 4 times a day. It's approved at 4 times a day for signs and symptoms. You can use this up to 4 times a day, and then many of my patients are using this 2 to 4 times a day. New category, so if someone says, hey, I can't have access to this, what do I do now? Well, there isn't anything that acts the same way as an anti-evaporative that's available at the moment as MIBO. So it is a tear stabilizer, and I think it's been a welcome addition, both in kind of primary treatment where someone comes in and maybe they're using a artificial tear. If you look at head-to-head, in the MIBO studies, MIBO versus hypotonic saline, it outperformed it at every time point. So I will switch that patient to MIBO and have good success. I've had good success in adding this on the back end of my treatment regimen after I've done some in-office treatments, and maybe they're on a nutraceutical or even on an immunomodulatory medication. Adding this for patients that have evaporative dry eye symptoms, burning, eye fatigue, fluctuating vision later in the day, those are the low-hanging fruit. Certainly if someone has a lot of inflammation on the surface of the eye or a lot of risk factors systemically, that would be pro-inflammatory or age, systemic conditions, lots of medications. You need to look and treat that part. But for these patients where they have MGD, they have rapid tear breakup time, they have burning, eye fatigue, irritation, and you see clinical signs of MGD, this is a go-to. So that is my 3-minute summary on MIBO. Thanks, James, for the question. Shala asks, would you recommend MMP9 testing over osmolarity? So great question. I have used both in my clinics. I have been using both for about a decade. I have gravitated towards now really primarily using osmolarity and just using MMP9 when I think I need to have another data point to help me with my decision making. So it's not an either or. What these tests will tell you, osmolarity is going to be increased, but it doesn't tell you how a patient got dry eye, whether it's a combination of aqueous deficient, evaporative, or both. But if it is high, there are no false positives with tear osmolarity, and tear osmolarity is part of the definition of dry eye. So how I've used this in a general clinic, say I'm seeing patients for cataract, glaucoma, retina, is I give them a speed questionnaire at check-in. Any symptom of dry eye disease, we will obtain a tear osmolarity test. I have that now as an objective measure point. And this, again, is not an OSD exam. This is just a general exam. Speed, osmolarity, I have that data point. If it's really high, I'm going to do something about it and maybe even look to someone have Sjogren's syndrome if it's up over 350. But it gives me something to go on, and then I have to investigate is why is that osmolarity high? But then as you treat the patient, whether it's topical steroids, immunomodulatory therapy, IPL, nutritional therapy, Lifitegrast or Xiidra, all of these things will lower osmolarity. I will use that to help track and guide patients. MMP9 is going to be elevated in dry eye. It's going to be a proteolytic enzyme. It will tell you that this patient has increased levels of MMP9, but it doesn't tell you why, because patients can have dry eye. They can have floppy lid syndrome is associated with MMP9 levels, allergic conjunctivitis, even basement membrane. So you still have to investigate what's going on to determine why that MMP9 is high. But as you treat that patient, if you found the right reason why that is elevated, you'll see that MMP9 go down. if you are using MMP9 and you have something like an IPL, if someone comes in and they have symptomatic dry eye MGD, they have lid margin telangiectasia and MGD, and they have a positive inflammatory, I do not need anything else to treat that patient with IPL as far as an indication. That is a slam dunk. That patient should be helped if I've identified any other comorbidities there. So I think both have a lot of utility. I think it's not an either or situation. The other point with osmolarity in a cataract refractive surgery practice is we know that this causes light scatter. So some of these patients that are 20/20 unhappy at the time or after they've had their cataract surgery, whether it's a monofocal IOL or a light adjustable or multifocal, there's a higher prevalence of patients that have hyperosmolarity. So hyperosmolarity in the perioperative setting is associated with unhappy patients. So I want to identify that prior to surgery so that we can address that appropriately. Thank you for that question. Our clinic is having trouble with MIBO prescribing. Whitney, if you missed our conversation 5 or 10 minutes ago, we kind of went over that. I would say send me a direct message and I will answer that offline here. We are 3 minutes left. Let's look at Carolyn. Carolyn says, advice on distinguishing dry eye disease from EBMD or basement membrane dystrophy in terms of symptoms and something there. So dry eye and basement membrane dystrophy, certainly the patient can have both. If somebody has pain, especially if it's unilateral pain, I want to make sure that it's not simply dry eye. Could they have had a corneal erosion? So I think that unilateral pain is more indicative of someone that has basement membrane dystrophy as one of our differentials we want to look at. Dry eye classically is going to have grittiness, eye fatigue, burning, foreign body sensation, and that's going to skew towards that versus EBMD. And then I think that maybe a pearl here is fluctuating vision. If the patient is fluctuating hour to hour, minute to minute, I'm very suspicious that's dry eye, and I would say it's almost always dry eye. But if it's fluctuating where, hey, one day is pretty good, and then a couple of days later it's not so good, you think about how that epithelium is turning over, and if they have an abnormal basement membrane, day-to-day fluctuations in vision versus hourly or by minute fluctuations in vision, I'm going to want to make sure I identify that EBMD in that patient that has that day-to-day fluctuation. Thank you. Yep, Whitney will get back to us here. And I will take one more question. Dr. Donahue says, what is your treatment protocol for a patient that has lost almost all of their meibomian glands and IPL may not be an option? We see these patients and IPL may still be an option, but it may not always fit into the patient's ability to access that for cost reasons as it's not covered by insurance. I'm going to make sure that I am aggressively treating ocular surface inflammation in that case, typically with both nutritional supplements and a topical immunomodulatory therapy. In a situation, if they had pretty decent tear production, I'd probably be going towards Xiidra for that patient, as that's a potent anti-inflammatory agent. You could use MIBO for that patient. I think you could use neurostimulation with a Tyrvaya. I think punctal occlusion would be part of our algorithm and or lacrimal occlusion with Lacrophil. And then these are also patients I think I would have a very quick trigger to a biologic. In my case, I would probably be using serum tears and using vital tears is how we've done that in our practice. We've had good success with that. These are difficult patients. I think helping them understand the level of their disease and if they have gland dropout showing that. But just because it looks like the glands aren't there in mammography doesn't mean that you can't get improvement in their gland function. So really look at structure and function to be able to determine what to do to help that patient. I made it. Hot seat number 2. This is great. I love this. Thank you so much for all the questions. Connect with me directly for anything more. And thank you again, BNL, for sponsoring this session. I think this was a winner, and I look forward to seeing you at closing remarks.